This meeting is being recorded.
I'm joined by the lovely Dr. Karacan from IVF Turkey. Hello, Doctor.
Hello, I'm very happy to meet you again.
Well, listen, I'm gonna steal your time for a little bit today because I want to get my head around protocols and what protocols mean. So I've got a list of questions here for you, and I'm really hoping you'll clear it up for me.
Okay, sure.
So why don't we start by, can you explain what the word an IVF or the term an IVF protocol means?
Okay, our main goal is in IVF is to get as many good eggs as possible, because the number of the more eggs we have, the higher the chances of getting pregnancy. So there are some ways, some methods to get good eggs out of this stimulation. Almost 20 years ago, we had only one medication to add ovulation induction agents in the process of ovulation induction in IVF. It was named GnRH agonist. The main problem, one of the problems in ovulation induction is having premature rupture of follicles. We don't want this problem occur during the process, because if it occurs, we may end up having no eggs at all. So we need to prevent early rupture of these follicles. Mm-hmm. Almost 20 years ago, we had only one medication to prevent LH surge, which is responsible of early rupture of the follicles. And we use GnRH agonist, GnRH medication to prevent LH surge, subsequently prevent premature rupture of the follicles. Mm-hmm. This medication, GnRH agonist, is started to use in the mid-luteal phase, previous the IVF cycle. And then it suppresses LH, this hormone, and then we use ovulation induction agents alongside with the use of GnRH agonists. It's so-called long protocol, but the aim is the same, to prevent early rupture of the follicles. But the obstacle in long protocol is to start this medication before the IVF cycle, before the IVF attempt. In the mid-luteal phase in the previous cycle. So it actually makes our work harder, because I need to call you earlier prior to initiating IVF cycle. But that was the only medication we had, and we used a long protocol to prevent LH surge. And however, within the last 10 to 15 years, there's another medication discovered, GnRH antagonist. This the goal is the same, the action is the same, to stop LH surge, to prevent LH surge, to also prevent early rupture of the follicles. But the GnRH antagonists are started on cycle day 6 or 7 or 5. So as you start taking ovulation induction agents, like for 5 days, then we add GnRH antagonists in order to prevent LH surge, subsequently premature rupture of the follicles. It's so-called short protocol. And then there have been many studies comparing short protocol to long protocol in terms of yield of eggs and pregnancy rate. And most of these studies did not show any one better than the other, any advantages of short protocol or long protocol. So none of them is superior to other one. So we use in Turkey, in almost 95% of cycles, we use short protocol. We start using ovulation induction agents on cycle day 2 or 3, and add GnRH antagonist on cycle day 5 or 6. However, some women might have heterogeneous response. Some follicles grow faster than the others. So short protocol may not be effective in that kind of women. So we choose a long protocol if we experience an heterogeneous response in a woman. That's the only way we use long protocol. But we otherwise we mainly employ a short protocol in almost 95% of our patients applying to our clinic.
So a protocol then is essentially your doctor's plan for you, in which he is then, or he or she is basically taking control of your reproductive system, in order to, well, that is the IVF process. And so you're saying, so it's a short protocol or a long protocol?
Right.
So, and my IVF was a long time ago. I can't even remember what I had, but I know I was down regulated first. So with that, I was on the long one?
Yes, it's long protocol because that's the purpose of starting this GnRH medication. In the previous cycle, we use this medication for at least 7 to 10 days and downregulate. Downregulate means suppress all your hormones in order to prevent early LH surge, surge of some hormones causing a rupture of your follicles. So we use GnRH hormone to suppress your hormones, so-called downregulation, and then start stimulating your follicles, ovaries. Yes, as you said, we need to take control of this hormonal system. Otherwise, we cannot plan the day of egg collection, the day of embryo transfer. We need to take control of all your hormonal status to arrange all these procedures. What you went through is long protocol, starting GnRH agonist in the previous cycle.
So with a short protocol, are you still, so how does it, so with a long protocol, I've had my system shut down, so to speak.
Right.
So does that happen with the short protocol or not?
If we downregulate your hormones, we continue using GnRH agonists. It's called long protocol. Yeah. But in short protocol, we start stimulating your ovaries without suppressing your ovaries, without suppression in the beginning of cycle. Then after 4 or 5 days of stimulation, then we start GnRH antagonists to suppress your hormones, same as we did in long protocol. But short protocol is more practical because most of our patients come to see us in Turkey on cycle day 2 or 3. So we don't have a chance to use medication before their cycles, their menstruation. As they come to Turkey, we start stimulating their ovaries, and 4 or 5 days later, add GnRH antagonists to suppress LH surge.
And is one, are they both as successful as the other?
Right, they are equally successful. None of them is proven to be effective or to be superior to the other one. So short protocol is as effective as long protocol.
But are there some patients where it's like, how do you determine who gets what? I know you said that you use the short one really in Turkey, but are there any patients that have to have the long one?
Yes, there are. If a patient develops heterogeneous different types of different follicular growth, sometimes some follicles grow faster than other one. And these patients may need long protocol to suppress all follicles in the beginning of cycle. I would say 5% of cases, 5% of women may need long protocol to get a better suppression. So this may be an indication to use long protocol. But on the other side, on the other hand, short protocol is mainly used in polycystic ovarian disease patients, because when we use short protocol, we have a chance of triggering maturation with different type of medication. By doing so, we may decrease the risk of ovarian hyperstimulation syndrome. So the main indicator or main indication of short protocol is in women with polycystic ovarian disease to prevent ovarian hyperstimulation syndrome.
That's interesting because I had the long one and I have got polycystic ovaries, and I think I've told you this before, I developed severe OHSS.
Yeah, this was years ago, but now if you undergo an IVF cycle, you need to get through with short protocol to prevent ovarian hyperstimulation syndrome. It's a certain indication.
That is, wow, that's fascinating. And how long, I'm obsessed with, well, as so many women are, how long an IVF cycle is going to take. So how long would it take with the short and how long would it take with the long? From the moment you start to the moment you take a pregnancy test?
Actually, in the long protocol, we start using GnRH hormone in the previous cycle. So after 7 to 10 days of using this medication, hormones get suppressed. Another almost 18 days is necessary. So 18 plus 7, almost 25 days for long protocol. For short protocol, as I told you, you start using medication as you start bleeding from the beginning of ovulation induction agents to the end, to the day of embryo transfer, almost 18 days. So long protocol 25, short protocol 18 days, from the beginning to the end.
Yeah. Wow, it's quick, isn't it?
I mean, it takes some time, but I understand many women coming to see us in Turkey, spending like 18 days, 15 days, 16 days in Turkey may be long, but that's necessary. We need to monitor ovarian response, follicular growth to get the ideal eggs, ideal number of eggs out of this.
Yeah. But I had a fascinating chat with Zuhal, your UK director, and we were talking about the process of traveling abroad for IVF. And she was saying, though, that if you are in the UK and you can't spend that length of time in Turkey, you can be monitored over here.
Right, right.
So you could guide the patient as to, you know, where to go and have monitoring, and then you work closely with that clinic where you're being monitored.
Yes, that's correct. So it's possible to monitor ovarian response in UK. We have some friends, colleagues living in UK. So you can start getting your injections in UK, and you can be monitored in UK like 9-10 days during the stimulation of the follicles. As you get ready, then you might travel to Turkey for egg collection and embryo transfer. By doing so, we may shorten the duration of your stay from 18 days down to like 7 days. So it's an advantages of having medications in UK.
Yeah. And actually, with the medications, would you give me like a prescription, like any doctor would give you a prescription for a drug, and then I can just go to a pharmacy to pick up IVF drugs? Is that where you can get them?
Actually, no, we can't give you prescriptions, but we have colleagues, physicians working with us in UK. So we refer you to these physicians, then they will be, prescribing medications to stimulate your ovaries. So you need to keep in touch with physicians in UK to get medications. Then they'll be monitoring your ovarian response.
Yeah. But what I mean is, but IVF drugs, you can get them in chemists. And in fact, I think you can buy them in supermarkets as well, can't you?
No, I believe you can't buy these medications at supermarkets. No, you can buy them in chemists.
In the pharmacy and the supermarkets, I mean.
Right, yeah, in the pharmacy and the supermarkets, right. So
yeah.
We don't have pharmacy in our supermarkets in Turkey.
Oh, yeah. You wouldn't find them
I'm
in
confused.
fake beans. Yeah, definitely go to a trusted pharmacist. And are there any side effects to these protocols?
Right. Mainly both side effects are similar. The major side effect is the ovarian hyperstimulation syndrome. So it may be a life-threatening condition. So we need to improve monitoring methods to decrease this problem to down to zero. So there are some centers called 0% OHSS risk. So that's our aim. That's we physicians aim to get 0% ovarian hyperstimulation rate. So that's therefore we like to monitor women closely every other day, sometimes every day, together with hormone analysis to prevent this problem. This is the main side effect of ovulation induction. The second one is to adjust the dose. Sometimes we lower or increase the dose to get the best out of you. That's the reason a physician should be experienced in monitoring, in following the patient with this medication. There was another issue of using this medication is that one was the risk of ovarian cancer or any health problems due to use of these medications. But according to recent studies, it has been published that there is no increased risk of ovarian cancer or breast cancer upon use of these medications. So using this medication for like 9 to 10 days does not put you into a risk of having gynecologic cancers or breast cancer.
Okay, that's very, very good to know. And then just one other thing, if your IVF doesn't work, if it was unsuccessful, when you then, if you're fortunate enough to be able to then go for another round, would you change the protocol or do you always stay on the same?
Actually, yes, we do change the protocol in hope of getting a better response. We sometimes decrease the dose or increase the dose to get a better yield, or switch from long protocol to short protocol or vice versa. However, there is no proof that changing protocol is beneficial to women who failed cycles in the past, even though there is no evidence, convincing evidence that changing protocol benefits all women. In clinical practice, if we fail with one protocol or twice, for instance, we'll opt to change or switch this one to like using tablets, using some other medications, some add-on treatments. So we do change our protocol to get a better response.
Yes. And am I right in thinking, having spoken to Zuhal about the process, she said that a patient would have all their initial tests that they would ask you for, and then once you get the test results back, you then sit down and you work out what protocol is right for that patient.
Right. After getting all these test results, histosapnogram and mainly AMH level, which shows ovarian reserve, and antral follicle count, which also gives valuable information on ovarian activity, we go ahead, get together, and review the medical history and the results, and decide on how to proceed, how to stimulate these ovaries. So there are many factors to adjust the dose to start with. For instance, in obese women, unfortunately, we need to increase the dose to get a better response. Obesity is an obstacle to deal with ovarian activity, ovarian function. So I strongly advise women to lose weight before attempting an IVF cycle. I recently examined a woman at the age of 19, having BMI over 40. Yeah, I mean, almost 120 kilograms at the age of 19. Even though we used high dose of medication, we couldn't get the best out of her. So it's also very stressful to us to deal with these women, obese women, to get the best out of them. So I strongly advise her to lose weight before any other attempt.
Yes. Yeah. Okay. And I think it's also really important just to end by saying that it's all these this terminology and the words, they're also new and alien, and it can seem quite overwhelming. But, you know, that's what you are there for. You are there to just sit, aren't you, with the patient, just to talk it through, and any questions they might have, you can just clear them up for you. Can't, you know, just so it's all, it's, you know, and you get your plan, don't you, with how you're going to do things, and your patient coordinator sticks with you, don't they?
Right. Yes, they do. And that's very important for them, for couples visiting us, to get a good counseling. That's very important, to counsel them. We give them a very scientific data, scientific truth regarding pregnancy rate through IVF, because it's important to know all these obstacles and pregnancy rate beforehand, in the beginning of the cycle. If they are told having very high success rate, they will be very disappointed at the end of cycle. So we need to be scientifically straightforward before starting IVF cycle. They are all get counseled thoroughly before any attempt.
Yes. Yeah, that's so good to know. Well, look, I'm going to leave you there because I know you're a very busy man, busy creating lives. What an amazing job you've got.
I'm very glad to see you.
Oh, I'm so glad to see you. And will you be at the fertility show?
I don't think so, but maybe next year I'll be with you at the fertility show.
Good, 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 because I'm dying to see you. I'm really, really dying to see you in person.
Thank you very much. Thank you.
Thank you so much for your time today.
Bye-bye. See you then.